Good evening.
Hello and welcome to the Aspen Young Innovators Surgical Technique and Wound Healing webinar. We'll give everyone about a minute to log on and then we'll get started. Thank you so much. All right, I want to welcome our moderators for tonight's webinar, Dr. Lubenow and Dr. Pack. Thank you so much. Enjoy the webinar.
Good evening, everyone, and welcome to this Aspen webinar on surgical technique. This particular webinar is being presented by the Young Innovators Committee of the Aspen organization, and as such represents the training opportunity where fellows in their current training year are helping train other fellows amongst their colleagues. Joining me tonight is my friend and colleague, Dr. Daniel Pack, who's going to introduce himself, as well as our presenting panel tonight. Dr. Pack.
Thanks, Dr. Lubenow, and thank you all for joining us for another very important topic for our Fellows webinar. My name is Dan Pack, and I'm one of the pain faculty members at Weill Cornell in New York City. And today we'll be talking about surgical technique, which is so critical as the field of pain management has really evolved to include many procedures that go beyond just your standard-of-the-mill injections and require sound surgical skills. So we're not going to speak on specific procedures today because we only have an hour, but we'll focus on a few really important subtopics. And all of these translate really well to other specific procedures that you might be familiar with, such as implantable therapies, minimally invasive spine procedures, and the like. And today we have the benefit of having three excellent fellows joining us as panelists. We have Dr. Fleming from the Cornell Tri-Institutional Fellowship, Dr. Miller-Lopez from the Northwell Lenox Hill Fellowship, and Dr. Kevin Shee from Rush University. We'll also save some time at the very end for questions, so please feel free to enter those in the chat box. But to kick it off, we'll talk about phases of wound healing. So with that, I'll yield to Dr. Fleming. Andrew, go ahead.
All right, thank you, Dr. Park. Good evening, everyone, and thank you for joining us tonight. So I'm going to start off our discussion with an overview of some of the fundamentals, which will be the phases of wound healing. We'll start off with this brief overview. So there exist 4 stages of wound healing after tissue injury, which exist as a continuum with one another, such that one phase depends on the successful completion of the preceding phase. What we can see in this graphic here are the 4 different phases. So in the bottom left of the graph, we have hemostasis, which involves coagulation, platelet activation, and I'll go over those things in a moment. We then have inflammation, followed by proliferation, and then followed by matrix remodeling. In this graph, we also see that the timeline for these phases is different for each one relative to the other, meaning that the first 2 stages are relatively short and occur within the first few minutes after tissue damage, whereas the last 2 stages occur over the course of days or weeks, even extending as long as 1 year in some cases. So I'll go through each of these phases in detail and hope that this can serve as a review of some key concepts, which can then be used to better understand optimal techniques for surgical closure. Next slide, please. So we'll start with a discussion of hemostasis. This occurs in the immediate 5 to 10 minutes after disruption of the vascular endothelium, which leads to the release of biogenic amines such as endothelin when served to vasoconstrict the local vasculature. Endothelial disruption also exposes von Willebrand factor and type 1 collagen fibers, which then bind to glycoprotein 1b and glycoprotein 1a respectively. You can see this at the bottom of this graphic where the platelets are binding via GP1b to von Willebrand factor. In addition to these protein interactions, the platelets then change shape and are able to express GP2b3a receptors. They also release alpha granules containing various soluble mediators, most notably fibronectin, fibrinogen, ADP, and thromboxane A2, which I'll discuss later. Platelets are then able to aggregate with fibrinogen and with the glycoprotein 2B3A receptor to form cross-links with one another that stabilize into a platelet plug. ADP and thromboxane 2 also serve a critical role via their respective G protein coupled receptors to further propagate platelet activation and aggregation. Ultimately, this signaling cascade produces this platelet plug that I mentioned, overlying the area of endothelial injury. Importantly, these activated platelets also begin to activate the extrinsic and intrinsic coagulation cascades that I'll discuss on the next slide. We can go to the next slide, please. So here we see the two main coagulation pathways, which are the intrinsic and extrinsic coagulation pathways converging onto the common coagulation pathway. The extrinsic coagulation cascade is independently activated by tissue factor, which is a protein that's released by damaged endothelium and is also exposed within the subendothelium after tissue damage, binding factor 7 and ultimately activating factor 10. Separately, factor 12 is activated by any contact with exposed collagen, specifically type 1 collagen. As you can see in the cascade, this ultimately leads to activation of factor 10 as well, which then ultimately allows factor 10 to cleave prothrombin to thrombin, consequently cleaving fibrinogen to fibrin and stabilizing those clots that we mentioned. As you recall, fibrinogen is important for cross-linking those platelets, and now that it is converted to fibrin, that clot becomes more of a scaffolding, a strong, sturdy scaffolding onto which various cell types can later bind and progress in the next phases of wound healing. Next slide, please. So this brings us to the second phase of wound healing, which is inflammation. This phase typically begins within the first minutes to hours of tissue injury, and it can last up to 10 to 14 days after injury. So to understand the events within this phase, it's important to acknowledge that during the hemostasis phase, those activated platelets also released various other growth factors and proteins, including P-selectin, platelet factor 4, TGF-beta and TGF-alpha, VEGF, and PDGF. One downstream effect of P-selectin expression and PF4 release in particular is the recruitment of other leukocytes such as monocytes, neutrophils, macrophages, and mast cells. What does this all mean in practical terms though? So whereas in the hemostasis phase, we had vasoconstriction, the next 5 to 10 minutes are predominated by vasodilation due to mast cell mediated histamine release. When we suture to close a wound, this transition is relevant for us based on our selection of sutures. We should select braided non-absorbable sutures, which provide a better scaffolding upon which fibroblasts can proliferate to produce stronger scar tissue and to maximize water tightness of the healed wound. For this reason, braided non-absorbable sutures are the optimal type of suturing, as an example, to use in an IPG implant. This results in the classic Ruber, tumor, Calor, and Doller inflammation as well when we see mast cells release histamine. And in this next phase, neutrophils predominate for the first 24 hours, serving to phagocytose foreign materials such as bacteria and damaged tissue. They also release critical cytokines and proteases that degrade damaged extracellular matrix proteins and activate fibroblasts and epithelial cells. Eventually, neutrophils are then eclipsed by macrophages, which are recruited in even greater numbers as in the next 2 to 5 days, the neutrophils begin to die off. We can go to the next slide, please. So at this point in inflammation phase, you can think of the macrophages as perhaps the most important aspect of this phase. They are present throughout the majority of this phase and play a critical role in laying the groundwork for the next phases of wound healing. As I mentioned before, macrophages are recruited to the site of tissue injury by soluble proteins released from activated platelets, as well as the neutrophils themselves as they die off. Macrophages actually perform many of the same functions as neutrophils, in that they also continue to degrade damaged extracellular proteins, but they are also able to secrete protease inhibitors, which better regulates tissue remodeling. They secrete many growth factors and cytokines that ultimately result in angiogenesis and fibroplasia, signaling that the inflammatory phase is ending and the proliferation phase is beginning. Prolongation of this inflammatory phase, as you can imagine, therefore impairs wound healing and increases scar formation. Next slide, please. So within the proliferation phase, we can consider 3 primary mechanisms at work which you can remember as the phase during which granulation tissue is formed and during which angiogenesis takes place. This typically spans throughout the first 30 days of wound healing. So the first portion on this slide is reepithelialization, which is of course which requires stem cells to be recruited in order to establish damaged epithelium. This occurs by recruitment of basal epithelial cells via cytokines and growth factors such as TGF-alpha, which are secreted by macrophages in the inflammatory phase. Secondly, as we see here with the capillary budding, capillary formation is critical to ensuring sufficient tissue oxygenation and to maintaining tissue viability. So this process is mediated by such growth factors as VEGF, as well as by microenvironmental factors like low tissue oxygen tension, low pH, and all of these things result in high density proliferation of capillary beds, which appear granular in nature, and actually where granulation tissue gets its name. Finally, the last part of this is that the extracellular matrix is synthesized in order to reestablish that protective barrier to prevent further fluid loss or bacterial contamination of damaged tissue. This process is primarily mediated by fibroblasts, which synthesize large amounts of type 3 collagen, elastin, and proteoglycans. Importantly, establishment of this matrix allows for contraction to take place via myofibroblasts, which is an important mechanism by which the edges of those tissue injury sites can begin to approximate. Next slide, please. So our last phase here is the remodeling and maturation phase, which varies greatly in duration, but importantly can last for as long as 1 entire year, if you recall from that first slide. During this phase, tensile tissue strength is optimized and collagen deposition becomes organized by conversion to type 1 from type 3. As we saw in the previous slide, type 3 collagen initially predominates after fibroblasts synthesize it in granulation tissue. Compared to the uninjured tissue, however, this immature scar typically only has about 25% of the tensile strength as compared to the uninjured tissue. The scar tissue remodels and matures via collagenases, matrix metalloproteinases, and other enzymes secreted by various cells within the wound bed. All of these ultimately serve to increase the synthesis of type 1 collagen, with type 3 collagen decreasing to about 10% of total collagen in the tissue bed. This remodeling ultimately results in degradation of the granulation tissue, retraction of those excess blood vessels, and increase in tensile strength that is in an ideal setting is about 80% of the uninjured tissue strength. Next slide, please. So this last graphic serves to demonstrate that flux of tissue composition that I just went over, with fibronectin and collagen type 3 being the most predominant matrix components within the first 2 phases, and collagen type 1 increasing in predominance during that remodeling phase. Ultimately, this increases the tensile tissue strength or wound breaking strength, as you can see here. Next slide, please. So finally, I want to leave you with some practical clinical pearls and commentary about why it's so important to understand these basic principles behind wound healing. Understanding the normal progression of wound healing, as we just saw, allows us to consider factors that might contribute to chronic wound formation. A wound that has failed to heal within 4 weeks should be considered chronic, and certain factors can increase a patient's risk for falling into this category. Older patients, for example, tend to have weakened immune systems, or weakened immune responses, and decreased cell turnover, increasing this risk for delayed wound healing. As you may also recall, various nutritional factors can impair immune function or collagen formation, such as vitamin C deficiency. Poor vascular perfusion, as with diabetes or peripheral vascular disease, can also contribute to delayed wound healing. Various medications, such as immune modulators, may impair wound healing. Obviously, radiation and chemotherapy may pose obstacles due to fibrosis, immunosuppression, and tissue damage. And infection will certainly delay wound healing due to increased tissue damage and prolonged inflammation at the wound site. Lastly, when we consider a surgical closure, as we will in the next couple minutes with our other presenters, it's critical to optimize suturing and surgical technique to balance the need for hemostasis with allowance for sufficient blood supply to facilitate effective wound healing. So with that, I'm going to turn it over to Dr. Lauren Miller-Lopez.
And thank you, Dr. Fleming, for that wonderful introduction. My name is Dr. Lauren Miller-Lopez. I'm a Northwell Health Pain Fellow, and I'm going to be speaking about surgical materials, suture needles, and commonly used surgical instruments. Next slide, please. So to speak about this topic, we need to start with the basic surgical tenets of Halsted. So who was Halsted? He was the co-founder of Johns Hopkins. He created the first formal surgical residency program in the United States, and he pioneered many of the surgical techniques that we use today. And the basic tenets consist of 8 main principles regarding aseptic technique and surgical closure. These include gentle handling of tissue, meticulous hemostasis, preservation of blood supply, minimum tension on tissue closures, accurate tissue apposition, obliteration of dead space, crush-free dissection, and principles of sterility. Next slide, please. So these principles of Halsted are still used today. The Neurostimulation Appropriateness Consensus Committee released their most recent recommendations for surgical technique for spinal cord stimulation in January of 2022. And this reflects many of the key principles of Halsted and also includes proper naming of instruments, suturing and knot tying skills, and the appropriate use of electrocautery. Next slide, please. So here we have the basic material to maintain a sterile field. You can see the first thing listed are hair clippers as opposed to a hair razor. It's important to note this distinction as shaving is associated with an increased risk of surgical site infection. We also have sterile towels, drapes, gauze, different types of cleaning solutions including ChloraPrep, iodine, and alcohol scrub, IABAN, light covers, and C-arm sterile covers here. And you have the cover that covers the C-arm itself, but in addition to that, you'll either have C-armor or half sheets on your surgical drapes to protect the surgical field from the C-arm. Next slide, please. And it's important to place the drapes in a certain manner after the skin is prepped. So first you're going to place your blue towels. They should not be picked up after placed down to maintain sterility. After your blue towels, you're going to place the adhesive IOBAN so that the skin is completely covered before you start. And this is to exclude all skin from the surgical incision and to limit infection risk from skin microbes. And the final step is going to be placing your lap sheet on top, as you can see on the left-hand side. Next slide, please. And this is a list of basic surgical instruments for spinal cord stimulator implantation, which we can see on a picture in our next slide. And here you can see our needles. This includes your introducer needle, your local needle, your finder needle, syringes, including your loss of resistance syringe, scalpels, spinal cord stimulator leads and anchors, as well as tunneling devices, and different types of pickups, scissors, and a variety of retractors, which we'll speak about more in detail later. And in addition to the instruments you see here, we also commonly use Bovie and suction devices. Next slide, please. So the first instrument we'll discuss will be scalpels, and their use is for the initial incision, cutting tissue, and it consists of a blade and a handle. And below we can see our blades, which are commonly referred to by their number. We see our 10 blade, which is used to make a large skin incision. The 11 blade, that's usually for stab incisions that require precise and angled movements. And our 15 blade, which is a smaller version of the 10 blade that you can use for finer incisions. To the right, you can see how to hold a scalpel. So there are 3 types of grips. There's the pencil grip, the palmed grip, and the one we see here, which is the fingertip grip. And in the fingertip grip, this is the most common because it's the most accurate and stable grip. It allows all 5 fingers to be on the scalpel while the palm has no contact with the scalpel, and it allows you to maximize your blade's cutting surface. And when using this grip, you'll exert pressure with your index finger and make a single pass incision while you use your non-dominant hand to hold lateral traction on the skin. Next slide, please. So our next instrument is the electrosurgery unit. It's often referred to as the Bovie due to its creator, William Bovie, and it's a high-frequency electrical energy system that allows you to both cut tissue and coagulate vessel. There are 2 types of Bovies: the monopolar, which is a stream of electrons delivered directly through the tissue. It travels through the patient and exits via the grounding pad, often referred to as the Bovie pad. There's also the bipolar forceps, and this is where the electron stream will remain between the 2 tips of the bipolar device. Next slide, please. So as we spoke about on the last slide, there are 2 main functions of the electrosurgery unit, and that's cutting tissue and coagulating vessels. And in terms of settings, it's going to depend on the tissue type you're cutting through for what settings you're going to use. They usually vary from 20 to 40 watts. Lower wattage is going to be used for more delicate tissues such as neural tissue, or if you're doing a revision and you're bovieing near an IPG. Whereas a higher wattage will be used when you're going through a thicker tissue such as the lumbar fascia. And it's important to note that you should avoid cauterizing the surface tissue, as this can cause inflammation, increase your risk of infection, and lead to poor wound healing. It's also important to note that there's no evidence that the use of scalpel, scissors, or electrocautery is superior to the other. Next slide, please. Our next surgical instrument is the needle driver. So what type of needle driver you're going to use really depends on 2 things, and that's surgeon preference and the depth of the tissue. So the 3 types of needle drivers we see below include the Webster, which is a delicate needle driver used for finer structures, a Halsey, which is a needle driver that has a scissor-like design, and it's used for larger needles than a Webster, and a Mayo Heger, which has a longer handle than the other 2 needle drivers. It can be used for deeper locations. And you can see on the right, there are 3 different ways to hold the needle driver, and no one is superior to the next. Next slide, please. So this is a depiction of how to load your needle and pass it through skin. So in the first row, you can see for loading your needle should be grasped near the tip of the needle holder and between halfway to 2/3 distance from the connection between the suture and the needle. In the second row, you can see the needle passing through skin. You can use the needle driver to pull through the needle to the other side. Next slide, please. Our next instrument are forceps or pickups. So they're used to manipulate, support, and retract tissue, as well as grasping sutures and needles. There are 2 main types: those with teeth, which pinch the tissue, and toothless, which are going to crush tissue and are preferred for skin approximation and avoid disrupting blood flow or injuring tissue. Next slide, please. And here are 3 common types of pickups that we use. So the Adsons on the left are toothed. They can be used for skin closure when we're dealing with more dense tissue. The DeBakey in the middle is toothless. It can be used to manipulate needles, vessels, fragile tissues, and atraumatically grasp tissue when you're dissecting. And on the right, you see a non-toothed pickup, and this is for handling fine tissues and for applying traction during dissection. Next slide, please. So much like our other instruments, there's a specific way to hold the pickups. So the pencil grip tip is the approved way to hold the pickups. You hold them in your non-dominant hand. This allows you to be free to suture, bovie, use a scalpel with your dominant hand, and this grip will allow you to delicately handle tissue. Next slide, please. Our next surgical instrument are tissue scissors, and these are used for both cutting tissue and cutting sutures as well as dissection. And there are two main classes of scissors. We have our Mayo scissors. They come in straight for cutting sutures, and they also come curved, and that's for cutting dense tissue. And then we have the Metz, and this is used to cut fine tissue and to perform blunt dissection. Next slide, please. Next, we'll be discussing clamps. So we have 5 types of clamps listed below. We have our hemostat, which is a non-toothed clamp. It can be used to grab tissue and vessels. The Kelly below that is really just a larger version of the hemostat. We have a Coker below that, which is a toothed clamp, and this is often what you use when you're removing an IPG during a revision case. And on the bottom, there's our Alice, and this has rounded jaws. It can be used to clamp towels. And to the far right, you can see our towel clamps, and these can be used to secure the drapes. Next slide, please. So next we have retractors, and these allow you to hold the incision open and have a clear view of the surgical field. So there are 2 types. There are handheld retractors, which include the Army, Navy, and the Sen Mueller, which you can see on the right-hand side. These are used to expose superficial sites. And we have our self-retaining retractors, which act via a ratcheting mechanism. And that is what the WED is on the right-hand side, also used for exposing superficial sites. Next slide, please. Our next instrument is suction. So this is used, as we know, to remove debris and surgical smoke. And there are 2 types. We have our Frazier suction, which only comes in a metal variety. It's used for delicate tissue. And we have our Yankauer, which comes in plastic or metal, and it can be used for suction of the wound and the skin surface. Next slide, please. And here are listed suture materials, including needles, sutures, skin glue, and staples, which we'll go into a little more detail on in the following slides. Next slide, please. So in terms of needles, we have multiple different sizes and shapes, as you can see on the right-hand side. A CT needle is a circle taper needle. This is usually used to close deep layers. It's a more curved needle and is helpful for fascial plane closure and more confined spaces. We also have an SH needle, which is a small half circle, and it's used to close more superficial layers. It's less curved and it's favorable for closing sub-Q and skin. Next slide, please. Needles also come in both tapered and cutting varieties. Tapered needles are blunt. They're used for delicate tissue like Scarpa's fascia. And cutting needles have a cutting edge and are often used for closing sub-Q and skin because it allows for proper tissue tension. There's additionally a reverse cutting needle, and this is preferred for cutaneous suturing because it reduces suture tearing through the skin and needle bending. Next slide, please. Additionally, sutures come in a variety of sizes. So the more zeros you see indicates a smaller suture diameter. So for example, a 4-0 is going to be smaller than a 3-0 suture. And it's important to pick the right suture size when closing. Too fine of a suture can lead to wound dehiscence if your suture breaks before the tissue heals. And too coarse of a suture can cause wound irritation and increase your risk of wound infection. Next slide, please. So sutures also come in both absorbable and non-absorbable variety. And both of these options have braided, which are higher tensile strength, and monofilament, which are less tensile strength. And our braided suture is going to encourage fibroblastic proliferation. So you're going to use this over hardware and anchors to create that hard, firm, and watertight scar. Whereas a monofilament suture is going to minimize fibroblastic proliferation and decrease scarring where cosmetic outcome is important. And of note, there's no clear evidence for staples, sutures, or skin glue being superior for skin closure. Next slide, please. And I'm just going to end with some practical pearls for sutures for neuromodulation. So to secure devices underlying fascia in your tissue pocket, you should use a braided non-absorbable suture. For fascial closure, you should use a braided absorbable suture. For superficial layer, you can use a monofilament or a braided absorbable suture. For dermis closure, you can use a monofilament absorbable suture, and for superficial skin, you can use either a monofilament absorbable suture, skin glue, staples, or steri strips. And just to point out, if you're doing a wound washout, you would want to use either a monofilament suture that is non-absorbable to minimize your bacterial adhesion to the suture, or you would want to use staples. And with that, I'd like to hand the discussion over to Dr. Shea.
Thank you, Dr. Miller-Lopez. That was a cogent summary of different surgical tools and the different devices we use in surgery. My name is Dr. Kevin Shea. I'm a current fellow at Rush University in Chicago, and I'll be presenting about surgical technique for a 3-layer closure. Next slide, please. I just wanted to review, to serve as the foundation before we get started here, Dr. Joseph Halstead's tenets. These were previously mentioned by Dr. Miller-Lopez, but I specifically wanted to highlight or emphasize the importance of two main points here. One is the preservation of blood supply, and two is minimum tension of tissues, as I find that these are less obvious culprits of post-operative wound complications. Next slide, please. This image demonstrates a typical tray setup for permanent spinal cord stimulator implant. The instruments and tools were reviewed, but I just wanted to kind of provide some more context and to reaffirm what you all may have already heard. The instruments you see here are as follows. Number 1, rubber shods for hemostats. Number 2, a glass loss of resistance syringe. Number 3, permanent ethibond suture, which we typically use for anchoring leads or the IPG. Number 4, dissolvable vicryl sutures, which can be used for closure of either fascial layers or subdermal layers. Number 5, a Yankauer suction. Number 6, Wheatlander retractor. Number 7, bipolar cautery. Although monopolar cautery I find is more commonly used for hemostasis. Number 8, a radiographic marker. Number 9, Mayo scissors, which I find is most typically used for cutting sutures. Number 10, scalpel handles. Number 11, Metzenbaum scissors, typically used for tissue dissection. Number 12, Adson Brown forceps. These are finer and more commonly used for superficial closure. Number 13, DeBakey-Gerald forceps that are more commonly used for the closure of deeper layers. Number 14, Sen retractors. Number 15, Army-Navy retractors. And number 16, Parker retractors. Next slide, please. This cartoon here views the anatomy relevant to an IPG pocket site. Given patients are typically prone for SCS lead implantation, IPG pocket sites are typically on the patient's posterior side, either the right or left flank. The process of pocket creation, as recommended by the NAC guidelines, imply that one should begin with sharp dissection through skin and through the loose areolar Camper's fascia until one finds Scarpa's fascia. That's demonstrated by the green fascial kind of opening here in the image. And then beyond that will be an avascular plane between the Scarpa's fascia and the deeper muscular layer. Blunt dissection can be used to further widen this pocket or this plane large enough to fit an IPG. Additionally, IPG should be implanted no deeper than 4 centimeters for rechargeable batteries and no deeper than 4 centimeters for non-rechargeable batteries, and no deeper than 2 centimeters for rechargeable batteries, as to minimize issues with charging and connectivity. Next slide, please. The 3-layer closure technique implies that one places sutures in 3 different planes. First is the deepest layer, or that fascial strength layer. The second is a subdermal layer, and the third is a superficial skin layer. Layered closures are typically recommended by the NAC guidelines to limit dead space and minimize tension of the closure, to minimize infection risk, and to improve healing. This image demonstrates the approximation of a deep layer with a non-dissolvable proline suture. Interrupted buried sutures within that robust scarpus fascia are typically placed first proceeding from the deepest aspect to the superficial aspect on the side, opposite to the hand holding the needle driver, and then from the superficial aspect to the deeper aspect of the opposite side of the wound. These deep sutures allow for the burying of the knot, and as such are named buried sutures, and should be spaced no more than 5 millimeters apart to minimize gaps. Next slide, please. The subdermal tissue layer helps reapproximate tissue above the deep fascial strength layer to minimize dead space. Dissolvable sutures, typically either a 2-0 or a 3-0, are best suited for this layer. Buried interrupted sutures are once again utilized, but this time one should take care not to violate the dermis at the most superficial aspect of each throw. Next slide, please. The third layer of closure is the superficial skin layer, as demonstrated by that kind of bottommost image on the right side of this slide. This layer is typically closed with a running subcuticular suture, typically a 4-0 of some sort of dissolvable monofilament suture. While this layer is most important for cosmesis, it is often the weakest layer. That means that reinforcement is important, and one should utilize either skin glue or steri-strips. Alternatively, as mentioned previously, staples or interrupted non-dissolvable monofilament sutures can also be used. Now, a few key points to remember during closure. Certainly, hemostasis is an important concept and an important end goal, but excessive electrocautery can lead to weakened tissues and inadvertent skin necrosis. Skin can also be easily bruised and macerated if one uses too hefty of a grip or too strong of a grasp, and should be avoided. Now, the mitigation of infection actually begins prior to closure. Copious irrigation of any wound or surgical site with saline is typically recommended. However, one may choose to include antibiotic in the irrigation solution, but per the NAC guidelines, there's currently no data that suggests that antibiotic-containing irrigation is more beneficial than without for infection prevention. Adequate hemostasis certainly is paramount, certainly not just for wound healing, but also to prevent infection. As subcutaneous collections of fluid can serve as growth medium for bacteria and as such become nidus for infection. One may also consider the application of vanc powder or vancomycin powder. However, the NAC guidelines recommend additional research into this topic before supporting its routine use. Next slide, please. Postoperatively, patients should be counseled to keep the surgical site dressings free from moisture and avoid bathing or soaking their wounds. Additionally, one as a physician or provider should look to optimize our patients' medical comorbidities. This may look like the reinitiation of blood thinners or perhaps more careful management of blood glucose. At a maximum, patients should be reevaluated in clinic 2 weeks after their operative date. This is a point in time at which permanent sutures, permanent non-dissolvable sutures, or staples should be removed. Patients should additionally be counseled for alarm signs of infection. This may include fever, chills, nausea, vomiting, erythema overlying surgical incisions, of which the IBG is the most common site of infection, or fluctuance or purulent drainage that is expressible from wounds. Next slide, please. The 3 most common types of infections following SCS implantation are superficial wound infections, such as suture seromas, deep infections, most commonly of the IPG pocket, and epidural space infections. Now, when a surgical site infection is suspected, patients should obtain blood work, specifically a white blood count, ESR, and a CRP. Depending on a patient's presentation, it can also be reasonable to obtain wound cultures and additional imaging. Specifically, when one is concerned for a potential case of an epidural space infection, an MRI with intravenous contrast should be obtained. A CT scan may be considered, but typically doesn't as clearly delineate the extent of inflammatory change. The NAC guidelines additionally recommend against delaying empiric antibiotics in patients with signs of developing surgical site infection and recommend adjusting any potential kind of antibiotic therapy based on culture and sensitivity results. Next slide, please. For deep infections, the NAC guideline recommends treatment with the incision, drainage, and unfortunate removal of hardware, in addition to a regimen of either IV or oral antibiotics. The duration of such therapy is to be determined with the assistance or the consultation of an infectious disease specialist or a microbiologist. Source control for deep infections is paramount. Typically, unfortunately, once again, this implies hardware removal. Important to note is that at the end of an explant procedure, one should use antibiotic irrigation or betadine solution, and a drain should be placed. That drain should be maintained post-operatively, or at least until the drainage decreases below 20 cc's per day for 2 consecutive days. Next slide, please. Wound dehiscence happens when one or more of the layers of closure fails to adhere or to heal together well. This typically occurs most commonly 5 to 8 days after surgery, and in patients with risk factors such as diabetes, connective tissue disorders, or cancer, or perhaps in patients taking immunosuppressant medications. Now, both over and under tension of wound closures can predispose patients to developing wound dehiscence. The technique for the management of wound dehiscence and neuromodulation procedures is largely anecdotal. However, it's reasonable to attempt a salvage procedure of a neuromodulation system if there's no concern for a deep infection with debridement and appropriate closure of the wound. Next slide, please.
Okay, I would like to open the presentation now to questions from the audience. And so if anyone in the audience has questions, you can please type them in to the chat box. One of the questions here for our panelists is, if one consistently gets bleeders in the pocket site, is it likely due to being in the wrong tissue plane? Any pointers to avoid? So with that question, Dr. Shi, would you like to address it? What they're in essence describing is that when you're making your battery site pocket, if you are consistently running into excessive bleeding issues, what's the reason and what can one do to avoid or minimize that?
Sure, that's a very good question. Typically, if you run into a lot of bleeders in the kind of creation or the identification of a IPG pocket, I find that it's typically because you're too deep or you've migrated or undermined into a vascular plane, typically a muscular plane. I think pointers to use or things to do to try and avoid this are to be mindful of the fascial layers and to take a step back and to evaluate just how deep you are in relation to the skin. There's no shame in taking a step back and kind of recapitulating your steps, perhaps identifying or dissecting a more superficial plane to try and look in a vascular location for the placement of your battery.
Another thing to keep in mind with this is that you want to dissect deep enough so that you're below Scarpa's fascia, because in this particular tissue plane, you'll find that the blood vessels are going to be running parallel to the skin or in a horizontal fashion. If you're above Scarpa's fascia, those vessels start to run radially or start to vertically transmit themselves to the skin. And so that's another thing to keep in mind. So if you're in the correct tissue plane, it's relatively avascular and it's going to be below Scarpa's fascia. I have a question here for Dr. Miller-Lopez. What is the advantage of using the circular tapered or the so-called CT needle when closing the deeper levels of the dermis right over your hardware?
So the advantage of using the tapered needle as opposed to using a cutting needle is that you have a lower chance of injuring any blood vessels in the area and causing bleeding in your wound, which you had just achieved hemostasis in.
All right, Dr. Pack, would you like to ask a question?
Sure. First of all, great job to all the speakers. My question is for Dr. Fleming. So, you talked really eloquently about factors affecting wound healing, like nutrition, age, history of radiation, etc. But what kind of pre-op measures can you take or optimize beforehand to reduce the risk of complications afterwards?
Sure. So obviously there's several things that you can consider doing. A couple of the common steps that people take include sending patients home with a chlorhexidine wash to do before they actually come into the hospital. So this will obviously minimize the skin flora that might contaminate a surgical incision. Another thing that can be done when the patient arrives to the hospital is a nasal swab for MRSA, which might guide antimicrobial therapy if an infection does occur. Other things would be patient-specific factors. So, for example, smoking cessation, ideally at least 6 to 8 weeks prior to the operation. For diabetic patients, critical to always check a blood glucose prior to beginning the procedure and appropriately treating if there is hyperglycemia noted on that blood glucose. In addition, we would want to make sure that we optimize the blood glucose management after the procedure is done as well, since that will obviously affect inflammation and wound healing afterwards.
I think those are all great points, specifically what you're talking about when it comes to perioperative glucose control, because we get a lot of people who come to us and say, well, look, the A1C is high, we can't proceed with an implant. And what we know now is that perioperative glucose control is generally considered more important than A1C levels when it comes to surgery, as immediate blood glucose management during the procedure itself and the recovery period has a stronger correlation with surgical complications. The risk of complications or infection when it comes to implantable therapies like spinal cord stimulators, depending on what you read in the literature, is anywhere from 3 to 6%, right? And this is in the studies that we oftentimes use to quote these things. And so these are experienced users, right? So you're talking, that's not an insignificant amount. If you're talking about 3 to 6%, that means 3 to 6 implants out of every 100 that you're doing potentially are getting infected and need to be explanted, right? So I think that taking those measures is absolutely crucial and trying to mitigate, whatever risk in terms of complications that may arise in the future. So thank you very much. I have a kind of another question for, and feel free to, anyone can kind of to jump in, but I'm kind of curious for all of our panelists. When it comes to your fellowship, obviously you have training. We have people here who have trained at really great institutions. But what other things are you guys doing to, I guess, refine your surgical technique? Because really, you only have a year to do this, right? So what else are you guys doing in addition to just your fellowship training? And anyone can jump in, really.
Really simple thing. Personally, I just have a kit that I ordered from Amazon. I think that it's very accessible for anyone to do that, and it's just something you can do at home on your own time to practice.
Yeah, I agree with that. I have a suture kit at home that I use and practice on. And in addition, I think going to workshops offered at conferences and through different companies has also been a great way to work on those surgical skills.
I agree. I think industry-sponsored events have been kind of where I've gotten the bulk of my practice. A lot of the cadaver courses I find have been really high yield.
Okay, another question has come in from the audience here, and that is thoughts on the 2-layer closure, deep and then well approximated superficial or skin, and then they add comma staples. And so I'll take that. A 2-layer closure is acceptable in people who have good quality skin, who have all their elements in their favor for proper wound healing. So these tend to be young, healthy people, people in good shape who don't have comorbid medical problems. As a general construct, it's useful to understand that a 3-layer closure is a stronger wound closure from a surgical standpoint. So classic surgical teaching will tell you that. I've had surgeons tell me that using a 3-layer closure is akin to what a brick mason does when he builds a brick wall. That is to say, he doesn't build each brick to be right above one another, but rather staggered in a certain pattern here, and that naturally gives the wall a greater degree of strength, as opposed to just piling one brick immediately above the other. And so with the 2-layer closure, recognize that you really only have that first deep layer that's going to hold the wound together. That's the strongest part of your wound. When you have a 3-layer closure, it's intended to have the first layer, the deep dermal layer, be a strong portion of the wound, and then you're going to oppose that second layer to be the deep aspect of the dermis, the deep aspect of the epidermis, and that's usually an interrupted suture technique as well. And that's going to add a second layer of strength to the wound. And that third layer is really just to oppose the skin edges, and it's primarily to promote the most cosmetically pleasing result. Some other questions here that have come up here is, how do you delineate between a patient with an infection of SCS who can be treated conservatively, I would assume just with antibiotics, versus removal of the stimulation device? And I'll throw that out to any of our 3 panelists here, or Dr. Pack. What do you do for that patient? And walk us through, you're 2 weeks, 2.5 weeks post, and the wound is a little bit red, and you're not quite sure if the needs to come to the operating room today, or what do you do next?
So I guess I can take that question. There's a lot of nuances to it. I would say that if you're doing an implant, they come back within a week and saying that they have this redness, then it's not likely to be an infection. It usually kind of presents itself and takes time to brew. Now, things that are indicative of more kind of a superficial infection, so maybe some slight superficial wound dehiscence, maybe some redness along the site, maybe a little bit of pain, I think are generally acceptable to kind of manage conservatively and try with oral antibiotics, among other things. If they show signs of deeper infection, right, they start to show, for example, pus coming from the incision, they obviously have constitutional symptoms, then that usually warrants something that requires a little bit more aggressive treatment and ultimately potentially an explant. I think we all try to do what we can to salvage as much of these implants as possible, because obviously we go through a lot of trouble to provide them for our patients. However, what we also know is that once these things get infected, it's very hard because it develops a biofilm essentially over this foreign device, right? And so once it shows signs of infection, oftentimes it has to actually come out. So I think those are general rules of thumb.
Another caveat to that is, if you suspect, or even if it's just looking a little bit mean, start by getting your blood tests. Dr. She mentioned is your C-reactive protein, sed rate, and then a white count, and then you can track that as you suggested. You see them back weekly, then, and if you see elevation in any of those, or particularly if you start seeing an elevation in all 3 of those, then you're more concerned about an infection. Then the second thing that you can do, and this is where a CT scan of the soft tissue can be useful in the abdomen or abdominal wall, because if you start seeing a fluid-filled collection around the battery, sometimes the radiologist can imply that there's an evolving infection there. And so these are all things that you can do in setting of managing these patients post-op. Another question from our audience here is, what about the use of the abdominal binder? Does this help if you do it routinely? And again, I'll throw this out to any of our panelists. Anyone want to comment on the use of abdominal binders? Dr. Shi?
Sure. I find that the use of abdominal binders is certainly helpful in preventing seroma. So that kind of maybe fluid collection that develops a week or 2 weeks after implantation operation. That abdominal binder applies external pressure to prevent that sort of fluid accumulation, and it can be helpful in advocating for good wound healing.
Okay, the next question comes in. If you do have an infection, do you have to place a drain, or can you just close and place staples after a good incision and drainage? Dr. Fleming?
I would say I would recommend placing a drain for sure, given that you want to monitor for how much output is coming from that area, even after you've debrided that tissue.
Dr. Pack, anything else to add to that?
Yeah, I think there's a lot of ways of being able to monitor for that type of stuff. One thing that my wife tells me, who's a general surgeon, is she kind of kiddingly always says, you guys deal with pretty superficial incisions in general, right? We're not dealing with anything in the peritoneum or anywhere else that's really concerning for kind of larger complications. And the reason why I say that is because oftentimes, if you have an infected site, you can do a drain, but oftentimes what I'll do is I'll debride wherever looks like friable tissue. You do a good washout of that area. Any part of the tissue that looks like it's unhealthy, I will try to essentially not only debride, but ellipse out. And then what you can do is put in some interrupted sutures with something like a nylon, leave it a little bit open if there's anything draining that can come out, and you can remove those 2 to 3 weeks later after putting them on some antibiotics. So I think it really just depends on the type of incision that you have and what it looks like.
Yeah, I think another option would be to use iodoform. I'm old school, so I tend to use that still, and we'll keep that in place for the first 24, 48 hours. And then one technique that one uses for closing the skin in that particular scenario is to use, obviously, like Lauren mentioned, would be the monofilament permanent suture, nylon being the most common. And then you can place that in a vertical mattress or a horizontal mattress fashion to add some strength to the wound. Another question here for our panelists is here. Which antibiotic do you recommend for empiric treatment for wound infection? And so, Dr. Miller-Lopez, what antibiotics would you use empirically for incipient wound infection from a stimulator?
So you would want to have something that's going to cover both gram-positive, including MRSA, as well as gram-negative and anaerobes as well. So in terms of specific antibiotics that you would use, I'd have to think about that, but you'd want to, I know you'd want to cover your gram-positives, your gram-negatives, and your anaerobes.
Yeah,
I mean, we like to use, I'm sorry, go ahead, Dr.
You usually use vancomycin because you want to have something that has a best coverage of staph, both MRSA and non-MRSA. And then you want to have something that's going to cover gram-negative. So one of the newer generation of the cephalosporins is most common. All right. We have time for, I think, one more question here. Can you discuss anticoagulation management after the procedure? The question is specifically, when do you start Xarelto or Plavix or warfarin after the implants? And this is laid out fairly straightforwardly in the ASRA guidelines. And so does anybody want to answer that particular question? At what point is it appropriate to restart the anticoagulant du jour? Dr. Sheet.
Typically, I find that ASRA guidelines have indicated that you ought to wait 24 hours before starting or restarting anticoagulation. Certainly, I think if you're participating in a trial of some sort and you do have epidural instrumentation with external extension, you ought to hold blood thinners for the duration of that trial.
And then the last question here is, when do you use a Tyrex pouch? And so in my own particular practice, I use the Tyrex pouch when you have patients that are at greater risk for wound infection, I wouldn't use it routinely. I don't think it's necessary because it has a certain cost associated with it that elevates the overall cost of the procedure. But if patients have a history of diabetes and are insulin dependent, for example, if patients are smokers, if patients have been taking drugs to alter their immune system because of their comorbid diseases, these are the types of patients where I would advise using the Tyrex pouch. It's a very simple thing to do. And so with that, I'd like to thank everyone for their attention and numerous questions that we fielded tonight. We have several more training and learning opportunities coming up within the Aspen organization. The first of which is our International Pain and Neuroscience Conference, which is going to be later on this year in October of 2025. This is going to be in London. Additionally, we have our annual Aspen meeting that's going to be in July, here mid-July of 2025. And as always, it's going to be held in Miami. We have our next Aspen webinar, Fellows webinar, which is going to deal with regenerative medicine techniques. And that's going to be in mid-April. I believe it's April 17th and 18th. And so with that, I'd like to thank Dr. Pack for helping me moderate this. All of our presenters, you guys did an excellent job today. And once again, thank you to the audience for your kind consideration of listening in. Good night, everyone.